So I take a quick listen to his chest, and I hear a pretty loud murmur, and his lungs sound a little wet. His extremities are cool and pale, and he's decompensating. The ICU resident shows up and wants to give him another liter of fluids because, well, he was hypotensive. But I feel a bit of caution about giving this patient that much volume. I needed more information. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Hey guys, welcome back to the podcast. Today's episode hits a little different as I was recently diagnosed with a form of cardiomyopathy myself. So more on that in a bit. But there are several forms of cardiomyopathy, and at some point in your career, whether you work in med-surg or labor and delivery, you will care for someone with cardiomyopathy. So I hope to break down the most common ones in today's episode. But my diagnosis, genetic arrhythmogenic cardiomyopathy, is not very common, and you may never encounter a patient with my particular diagnosis. But for those that are interested, I'll be releasing a bonus episode pretty soon to tell you about my arrhythmogenic cardiomyopathy due to pathogenic FLNC gene mutation and my journey towards getting this diagnosis and what's next for me on my treatment plan. I have deep dove down this rabbit trail researching everything I can about it, so I look forward to sharing with you. Stay tuned for that episode. For now, let's dive into this case about my patient to set the stage for us to discuss hypertrophic, dilated, and restrictive cardiomyopathy. So, as we talk about it, try to put yourself into my shoes. All right, it's 6:45. I just got reported from night shift, and I'm still stocking my fanny pack when the broadcast comes across my work phone. Rapid response, room 812. Side note, the room, age, and name of my patient have obviously been changed to ensure confidentiality. Okay, so I head to the med-surg floor where I find a 20-ish-year-old male, Ben. He's sitting bolt upright in the bed, clutching his chest, dripping in diaphoresis, breathing like he just ran a marathon. And the primary nurse tells me, this is Ben. He was admitted overnight for chest pain and syncope with exertion. He had a syncope episode while playing sports, and his teammates called an ambulance and insisted that he come here. He was fine until now. His skin color is just not right to me. He looks otherwise healthy, though, and actually pretty physically fit. But now he's kind of pale, extremely diaphoretic, like soaking through his gown kind of sweat. So I introduced myself. Hey, Ben, I'm Sarah, the rapid response nurse. You look uncomfortable. Can you tell me what you're feeling? He keeps saying, I feel like I'm going to die. My chest is so tight. I can't breathe. Now, pause. Anytime a patient says that to me, the alarms are just going off in my head. That sense of impending doom plus diaphoresis plus chest pain, I'm not messing around. And I can feel myself going into, oh shoot, this patient's going to code mode. So I'm trying to balance communicating a sense of urgency to the other nurses in the room without freaking Ben out even more. What do you say when a patient says, I feel like I'm going to die? Even though the nurturer in me wants to say, you're going to be okay, I know better than to ever say that to a patient. I have, unfortunately, learned the hard way on this one. And the truth is, I don't know if he's going to be okay. I don't know if any of my patients are going to be okay. I know I'm going to do my best. So I responded with what I do know, but started with validating his experience. Ben, I know this is super scary, the chest pain you're feeling and all these people in your room, but me and this team are going to take such good care of you. I'm going to be here with you and walk you through what we are finding and how we can help. The team had been trying to take a blood pressure, but he was moving around a bunch and the cuff had just been cycling and not giving a reading. I was able to palpate a radial pulse at least, but man, was he diaphoretic. I wasn't sure if it was the bend or the machine, so I took out my little portable monitor that I keep in my backpack and adjusted the cuff on him and said, "It's really important that I know what your blood pressure is, Ben. Can you try to hold this arm still so we can get a reading?" I signaled to the nurse tech to come over. "Ben, this is Danielle. She's going to hold your hand to help remind you to keep it still so we can measure your blood pressure." He nodded and looked at Danielle with gratitude. He seemed to appreciate having the hand to hold. By the time I finished putting him on my ECG monitor and pulse ox, his blood pressure finished cycling. 84/42. Heart rate, 142. Looks like AFib. Oxygen saturation, 89% on room air. And he's working hard to breathe. So I throw my nasal cannula at 4 liters, and his oxygen saturation improved to 94%. The nurse gives me more information. So he has a history of, quote, borderline EKGs, whatever that's supposed to mean, since high school. He was never fully worked up. Now, in hindsight, I'm guessing he must have had like deep Q waves or signs of left ventricular hypertrophy or repolarization abnormalities, but he didn't come with those old EKGs from high school, so I actually don't know. This is the first time he had ever been hospitalized for syncope. So the ER gave him a liter of fluids. They controlled his heart rate with a whiff of diltiazem. His labs looked fine. His CT head was negative, but he was still in AFib. So they admitted him for syncope, and for the cardiologist to see him would actually be this morning now. Okay, so I take a quick listen to his chest, and I hear a pretty loud murmur, and his lungs sound a little wet. His extremities are cool and pale. He's decompensating. The ICU resident shows up and wants to give him another liter of fluids because, well, he was hypotensive. But I feel a bit of caution about giving this patient that much volume. I needed more information. Okay, let's pause here and recap. Remember, you have the benefit of approaching this case with the knowledge of the ultimate diagnosis, which is hypertrophic cardiomyopathy. But we haven't finished his workup. I don't have an echo yet. I have blood work that isn't that alarming. A young, athletic, otherwise healthy patient who presented with AFib RVR. He was rate controlled in the ER with IV fluids and diltiazem, but there seems to be something more going on. You know, in hindsight, that small dose of diltiazem, which is an appropriate treatment for most patients in atrial fibrillation, but in retrospect, could have worsened his preload and contributed to his hypotension, given what we later discovered. So now he's presenting to me like cardiogenic shock. We have hypotension, hypoxia, though yes, it was corrected with a couple liters of oxygen. I'm so concerned though. A 20-ish-year-old patient with no respiratory history should not be satting 89% on room air. So here's the discussion I had with the resident as we collaborated on how to best approach this patient. "Doctor, I have concerns about giving that much volume as this is kind of presenting like cardiogenic shock, not hypovolemic. I know he came in pretty dry after playing sports, but they gave him a liter in the ER, and that was just a few hours ago. And when I listened to his lungs, I heard a murmur and some faint crackles. But here's my dilemma. I want to rate control him with beta blockers, but I have concerns about giving a beta blocker with the blood pressure of 84/42. What are your thoughts about giving just like a 250 cc fluid bolus to bump up the pressure, and then we can administer the beta blockers? We can always start a vasopressor if we need to. I also want to know what his heart actually looks like. I have POCUS probe in my backpack, or I can call for a stat echo." The resident agreed. That was a good plan for now until we got more information. So he asked me to call for the stat echo, and I asked him to call the attending just to get his insight. Okay, so you can Monday morning quarterback our decision. I totally get that. I do the same thing to myself, actually, deciding whether this was the right or wrong move for this patient, but here's how it played out. So I gave that 250 cc fluid bolus, and I pushed the first 2.5 milligrams of the metoprolol, so just like a half dose. I rechecked his blood pressure after the fluids plus the beta blocker, and now his blood pressure is 95/50. And his heart rate had responded even to that small dose, and it come down from the 140s to the 120s. So I gave the second 2.5 milligrams, and his heart rate improved even further, like 105 to 110-ish, and his blood pressure stayed about the same. So that's kind of my go-to approach for beta blocker administration in the face of soft blood pressures. I'll give half, see how they respond before proceeding with the whole dose. I can't take it back once it's administered. So soon after we got his heart rate a little better, blood pressure seems to be stable, the attending arrived. And he put the ultrasound probe on the patient's chest and said, he has a thick septal wall, partially occluding his outflow tract, and his left ventricle is very thick. And then on lung exam, he has B lines, which is indicative of pulmonary congestion. Bam! That is just what we needed to know how to manage this patient from here. So let's break it down. What is hypertrophic cardiomyopathy and how do we treat it? So hypertrophic cardiomyopathy is a genetic disorder where the myocardial muscle, especially the intraventricular septum, becomes abnormally thickened. But the heart muscle is different than the biceps. Biceps, bigger is better, right? But bigger is not better or stronger when it comes to cardiomyopathy. You don't want a big old heart. Thicker muscle isn't any stronger. It's actually stiff and non-compliant, which is double bad. And this causes two huge problems. In many cases, the thick septum bulges into the left ventricular outflow tract, especially during high contractility states like exercise or stress. So yesterday, Ben was exercising, and today he is stressed. And the result? Blood has a hard time leaving the heart and cardiac output drops. Additionally, that big, thick ventricular wall takes up real estate in the heart that should be used as fill space for blood volume. So not only do you have low cardiac output because you can't get the blood out of the heart, you also have this thickened myocardium, and so there's less space for blood to get into the left ventricle as well. Think big wall, small chamber, low stroke volume. And this is often made worse by tachycardia. There's not enough time for the ventricle to fill. Hypovolemia, well, there's less preload or less volume to start with, equals more obstruction. Or vasodilation, after load drops, the blood vessels dilate out, and this actually worsens the obstruction. So a left ventricular outflow tract obstruction, or LVOTO, in hypertrophic cardiomyopathy can be attributed to two main causes. The first, we talked about this increase in septal thickness. This narrows the exit for blood to make its way out of the left ventricle and into systemic circulation. And second, the velocity of the blood being ejected through that narrowed outflow tract can actually change the functioning of the mitral valve. Systolic anterior motion, or SAM, of the mitral valve is a common consequence of HCM, or hypertrophic cardiomyopathy. That's when the valve leaflet itself kind of flops over and obstructs outflow from the ventricle. That chronic trauma leads to structural damage and mitral regurgitation, all of which are just going to worsen the clinical picture for this patient. Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode. So, when Ben gets AFib with rapid ventricular response, it's just a disaster. Tachycardia is extra bad for someone with hypertrophic cardiomyopathy. Not only does he lose his atrial kick, which helps to propel the blood forward, but the tachycardia means he's losing fill time. That is double hit to the stroke volume and therefore his overall cardiac output. But just wait, there is more. The thickened ventricle can't relax. It's thick and stiff. So even if the heart squeezes hard, it doesn't fill well. These patients often have perfect or even high ejection fraction. And that can be misleading because what really matters is how much blood is actually being ejected from the heart, the actual stroke volume. Ejection fraction is the percentage of blood of the total volume hanging out in the ventricle during diastole. Like what percentage of that blood is squeezed out? So with most heart failure patients, we want to know the EF. Like what is their F? Is it 65%? Great. Is it 25%? Not so great. But that percentage is not what we want to know in this particular type of cardiomyopathy. So the percentage is not the number we're looking for in these patients. One of the issues with hypertrophic cardiomyopathy is there isn't enough space in the ventricle to create an adequate stroke volume. So the concern for these patients with the big stiff ventricle is increased left atrial pressures as blood backflows into the left atrium, pulmonary congestion as blood backs up into the lungs, syncope from decreased cardiac output, dyspnea from decreased cardiac output, and also possibly pulmonary congestion together. Unfortunately, sudden cardiac death is often the first symptom of hypertrophic cardiomyopathy. The symptoms are so vague. I mean, fatigue with exertion, like don't we all feel fatigue with exertion? Hypertrophic cardiomyopathy is one of the most common causes of sudden cardiac death in people under 35, especially in athletes. Studies have shown it accounts for up to a third of these deaths. The lucky ones, like Ben, have the syncope and get a cardiac workup and get the diagnosis that can lead to life-saving interventions. So that leads to my next question. Why did Ben decompensate today? Has he not had this his whole life? All right, let's go back to the case. So Ben likely had a combination of things happen in the last 12 hours. He most certainly had pre-existing HCM that was undiagnosed. No one's ventricle gets that thick overnight. That plus the exercise-induced tachycardia, plus the atrial fibrillation, which dropped his cardiac output and caused the syncope yesterday afternoon. He probably was volume depleted upon arrival to the ER. But something happened this morning that irritated his atrium or shifted his preload or activated his sympathetic nervous system, making him become tachycardic again. And this combo led to severely reduced preload, the outflow obstruction, acute pulmonary edema, hypotension, hypoxia, panic because he can't breathe. So now there's this sympathetic overdrive, which just made things worse. It is a spiral. And without quick intervention, these patients can arrest, especially in settings of VT or VF, which are also common with hypertrophic cardiomyopathy. So what do we do for Ben or any patient decompensating from hypertrophic cardiomyopathy? Well, first, we have to oxygenate hypoxic people, right? So turn on the supportive oxygen, elevate the head of the bed to reduce that pulmonary congestion, like support their breathing. Next is rate control. I can't stress enough how rate control is important in patients with these little tiny ventricular spaces to take on blood volume, right? And this AFib with RVR was killing his cardiac output. So your best choices are some sort of beta blocker like metoprolol that we used. This will slow the heart rate, kind of reduce the contractility a little bit. You want to avoid inotropes like dopamine. They're just going to worsen the obstruction. You may, if you need to, consider amiodarone, but diltiazem probably wasn't the best drug for this particular patient. Next is volume resuscitation. I know, he's in heart failure. Fluids seem counterintuitive. But in hypertrophic cardiomyopathy, especially with these little outflow obstructions, small fluid boluses can actually improve preload and reduce that obstruction. It is such a balance. So we gave Ben that baby bolus, the 250 cc's, just to bump up his pressure a tad. But then we ended up having to give him Lasix later. I mean, once we saw the B lines on the ultrasound and his work of breathing wasn't really improving too much, we carefully gave that dose of Lasix, ensuring that we weren't going to worsen preload too much. You know, volume resuscitation is very tricky and super nuanced when treating patients with HCM. So if you can, using dynamic measurements of stroke volume is probably the best way to deliver volume resuscitation intelligently without just guessing. The clinical picture can be so confusing with regards to if patients do or don't need more volume. Next is avoid vasodilators, like no nitro, no morphine. Medications that lower afterload actually make the obstruction worse. Next, you may need vasopressors. But not all vasopressors are equal in this situation. So if the blood pressure keeps dropping And more preload would make things worse, like giving a liter of fluids for blood pressure control was not in his best interest. Well, it's time to start a vasopressor then. And this is the perfect situation for a pure alpha agent like phenylephrine. Phenylephrine has no beta activity, so it does not increase heart rate, and it does not increase contractility, both of which might worsen that dynamic obstruction. All phenylephrine does is clamp down the pipes. It increases afterload by constricting the blood vessels and hence increasing blood pressure. And finally, these patients need to be in a critical care unit because they need to be on advanced hemodynamic monitoring where we can get constant feedback for how they're doing. This is not a patient to be on the med-surg floor. He needs that continuous monitoring, continuous telemetry, and further antiarrhythmic support. So how did Ben do? Well, I did end up having to start him on phenylephrine, but we got him rate controlled. He only needed a low dose. He was worked up by cardiology and was placed on an appropriate medication regimen, and an implanted cardioverter defibrillator was placed in his chest. So if he were to go into a ventricular arrhythmia or even AFib with too high of a rate, the ICD would fire and get him back into a slower, safer rhythm. Ben is lucky. Many young athletes with HCM collapse and don't get back up. Like I said, and it's often undiagnosed until it's too late. So here's some key signs to catch it early. Patients that have this syncope with exertion, a family history of sudden cardiac death, harsh systolic murmur that increases with Valsalva, and EKG abnormalities like DQAs or left ventricular hypertrophy. These patients need screening echoes, lifestyle counseling, and an ICD placed. Now, before I summarize the key pearls for hypertrophic cardiomyopathy, I wanted to briefly mention the other types of cardiomyopathy. So the next common one is dilated cardiomyopathy. This is where the ventricles are stretched out and dilated, and the ventricular wall is thin and usually weaker, leading to decreased contractility, a decreased ejection fraction, and ultimately decreased cardiac output. I have a great case in the queue for you all on that one. There's also restrictive cardiomyopathy, which is just what it sounds like. The ventricular wall is stiff and restricts proper filling. And of course, arrhythmogenic cardiomyopathy, which is what I have. And that's where there are problems with the cellular matrix that affect electrical conduction and put the myocardium at risk for arrhythmias. There are also a ton of subtypes of cardiomyopathy, like Takotsubo cardiomyopathy, which I did a whole podcast episode on. It's episode 98, if you want to check it out. There's also peripartum cardiomyopathy, which is discussed in episode 132, where I interviewed Tiffany, who is a nurse that's living and working with an LVAD as a result from her peripartum cardiomyopathy, and a handful of other versions of cardiomyopathy. And often, they actually kind of overlap each other. Like people with hypertrophic cardiomyopathy or dilated cardiomyopathy can end up becoming more arrhythmia prone. And my genetic condition predisposes me to dilated cardiomyopathy. But there is hope. Modern medicine and even advances in genetic science have come a long way. And the medication and surgical treatment options that we have today would blow away the cardiologists from the 1990s. So I really look forward to diving in more with you on this topic. Okay, let's wrap up with what our takeaways are as the bedside nurse for managing patients with hypertrophic cardiomyopathy. All right, first, don't blow off exertional syncope, especially exertional-related syncope in young people. That should be a red flag. Next, tachycardia is not always compensatory. In fact, in hypertrophic cardiomyopathy, I would say tachycardia is the enemy. But beta blockers are your ally. Inotropes, not so much. Volume resuscitation is tricky, but sometimes necessary. And finally, ask about family history. A 30-second question could save a life. I have a lot more to say on that in my next episode because someone asking my cousin that might just have saved my life. So I can't wait till our next episode because I have so much more I want to share with you. But for now, I will close by saying this. When you are caring for a patient with cardiomyopathy, remember, it's not always about how strong the heart beats, but also how well it fills, how rhythm and volume work together in harmony, and how your calm presence in a moment of chaos can truly make all the difference. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.